First up, we've got Hannah Thould, who's going to be talking about optimizing resourcing for same-day emergency care. Hannah's one of our many clinicians that I alluded to earlier and has a fantastic story to tell. So over to you, Hannah.
Cool, I will just share my screen for everyone. So hopefully you can see that if my computer decides to load it.
Yep, there you go. It's come through.
Lovely. Um, I wanted to talk about optimizing resourcing for same-day emergency care units. I am an acute medical registrar. I work at UHBW, which is in Bristol. I'm also Royal College of Physicians Chief Registrar for my trust, so I have dedicated time looking in for management and organisational aspects of kind of being a doctor. And I'm a clinician researcher looking into health systems research. I had absolutely no data science or coding background beyond the fact that I've done a science degree. I've tried to teach myself R and Python before in kind of various analytical concepts and when I've been in research, but have utterly failed. So came in from absolute zero. Initially, I wanted to use research, machine learning to investigate the ideal patient for SDEC, which is a relatively new way of working in the NHS aimed to kind of reduce the amount of patients who are staying in hospital and treat them kind of as they come back on it in a day unit type model. It's currently streamed by nurses and doctors in my hospital with lots of kind of wiggle room. And basically, there's no kind of standardized way of running an SDEC at the minute. And I wanted to see if we could find the ideal patient for it. I quickly found out that we didn't have the data for this. We needed a large data set in one place. All of our initial set of observations were done on paper, all the clerking, so that's taking a history, and the drug prescriptions are on paper, and everything is coded in different ways with lots and lots of free text. So I've had to kind of park that one. Hopefully I can come back to that one in the future. So I had to have a rethink. And within my role as Chief Reg, I was asked to have a look at being a kind of the medical take. And so what is the medical take? It's the process by which a patient is seen by clinical staff to make a diagnosis. You see a nurse, you see a doctor, and then the decision is made. Do you go home? Do you stay in hospital? Why is this a problem? Well, there's been a really increase in 12-hour waits, as you've heard kind of from previous people talking about this. And 12-hour waits in hospitals are linked to increased morbidity and mortality. And in 2023, there were 14,000 excess deaths related to 12-hour waits in hospitals. So it's a really, really significant problem. So I wanted to see if we could find a solution to the 12-hour wait and improve the efficiency of the medical take. And I wanted to know where we should invest in order to do this. And so I came up with the idea of creating a discrete event simulation model to explore this. This started with process mapping. So people come into hospital, they see a nurse, they see a doctor, and then we make that decision. In my trust, it looks something more like this. This is a simplified model. It's a very complicated process, and I don't think I'd fully understood how complicated it was until I really put it to paper. And then, like everyone else, I decided to make a Streamlit model, which hopefully I can play for you here. So this was my medical take Streamlit model. Basically, I wanted to make it as successful as possible. So that people could use it with kind of no coding experience. It's point and click and it's browser-based interface. It's got a couple of pages at the beginning of kind of how to use it and the fact that it's significant assumptions, like all of the investigations that are done simultaneously, and every patient needs admission. And I guess a bit of background to the medical take. On the left, you can see that I can alter the input parameters here. So it's the number of people, of doctors, the number of nurses, the SDEC opening times, and then the cubicles and the number of AMU beds as well. And then once we run the simulation, you can see the results, and it's time until decision to admit. And then we can have a look at the clinical queues over the time, and you're looking at those for consultants, for doctors, and for nurses. And then the time to AMU bed from admission. And then to look at this in some more detail, you can look at kind of some summary results, looking at the averages. And then this is available to download as a summary onto a PDF. So in terms of outcomes from my model, I've been predominantly looking at staffing and bed base. So here you can see that kind of the base of two doctors in SDEC and 4 take doctors. So that's kind of doctors who are covering A&E and then also SDEC. Is our base in our hospital. And if you add 2 doctors into the take, you can see that it does 2 doctors into SDEC, it significantly reduces the clinical queues over time. But interestingly, if you add 2 doctors into the take rather than into SDEC, it makes a really big difference into the kind of clinical queues. And I think that's really interesting because it shows that you can use the same resource in different places and it has a really different impact. What is kind of worth being aware of, this is not done with historical data at the moment. It's been very difficult for me to get historical data. And so there's no kind of 24-hour variation in patients' attendance. I think if you had more patients attending in the day who would come through SDEC in the model, that might look a little bit different. Obviously, you can see here, if you add more doctors into the system, it kind of reduces the queues for people to see them, and that's kind of fairly self-explanatory, but it was reassuring to me that the model was kind of working in the way that I wanted it to. The other thing I looked at was in terms of bed numbers. So this is going from 30 to 45 beds in our AMU unit. And you can see that here it kind of stops at 12 days. It's actually run over a 2-week period. And that's because AMU's full and the entire system is kind of ground to a halt. Whereas if we add 15 beds in, you can see that kind of patients come in, come out, and it's kind of a nice steady flow. And I think this kind of looking at things like this would be very useful for looking at winter pressures, looking at a more targeted way of where do we open beds, and exactly how many do we need to open, because that's going to allow us to kind of plan staffing as well. So in terms of organisational impact, we're currently going through a process mapping stage of the medical take, and we're also redesigning the resident doctor rota, looking at kind of how we run the acute teams, and then also how we reduce the 12-hour waits. And I think one of the things that I wanted to do in my year as the Chief Reg was to show the value of clinicians with data skills, that we have the ability to add a different perspective in service planning. I think one of the interesting things was that when I was discussing some of the machine learning ideas initially with some of the data analysts in the trust, they had no idea that our initial observations were done on paper. So the first set of observations, so that's blood pressure and heart rate, that they were using to kind of predict patients was actually not the first set of observations. So that means that patients have already had some treatment, and it means that if you're doing kind of a virtual triage, it's a completely different cohort of patients. So next steps, I need to validate the model. I really want to get hold of some historical data and run it through the model to see what it looks like. There's lots of further optimization on the model and kind of ongoing process modeling to work on with the take. I really want to extend this model to introduce kind of a random pause to affect issues like bed moves, notes going missing, and I think that this would be helpful because it could give evidence for things like moving to electronic prescribing, electronic notes, and reducing kind of patient bed moves throughout the trust. And then hopefully I'll be able to work alongside HMSAs in the trust to continue developing the model. So what have I learnt? I've learnt lots of skills. I couldn't code at all before this, but I think aside from coding, one of the really big things is it's really changed the way I approach a problem. I think a lot more about the data that I'm going to need, how I'm going to get hold of it and what it looks like. And I've also found myself looking at problems when I'm at work, being like, I wonder if I could kind of use some of the ways that HMSA's taught me to kind of tackle that problem. And my personal next steps, I've accepted an NIHR academic clinical fellowship, a national training number in acute medicine, and I really want to use the skills from HMSA to kind of keep kind of going with the ongoing health systems research. My lessons kind of in a broader sense, so I think again lots and lots about data and where we get it from. Lots about coding and how you approach a problem. For me as a resident doctor, it's been really good to be involved in a longer project. We move a lot, so I move jobs normally every 4 months. And so being involved with kind of a set of data analysts and in a problem which has been over kind of 15 months has been really great. And I think it's kind of model to other people the role of the clinician coder and kind of the impact that we could have. My advice for people who want to do it would be think about the data early, think about the questions you want to answer and how you build a model to answer those. Work in a team if you can, because the different perspectives are great, but I'd really, really recommend HMSA. It's fast-paced, supportive, and many thanks to Dan and Sammy.
That's brilliant. Thank you very much, Hannah, and fantastic timekeeping again. So brilliant. Thank you. Any questions for Hannah? Pop them in the chat. I think there's some really fascinating results you're getting out there, Hannah. So I can't wait to see how this progresses and how that turns into impact for the organisation. But it's great to see so much engagement already.